All right, good morning, everyone. Today's June 16th, 2022. I'm Madeline Verhofsek, Chief of Medicine here at St. Joseph Healthcare Hamilton, and I'm delighted to welcome you all this morning to our medical grand rounds. I'll bring up the next slide. And the next slide, please. So as we start these rounds, we'll do our Indigenous land acknowledgement, and also recognizing that June is National Indigenous Month, and Tuesday, June 21st is National Indigenous Day. And it's an opportunity for all of us to reflect on the history, present and future of our Indigenous peoples. So we acknowledge that St. Joseph Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee Nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And that brings us to our presentation for today. So I'm delighted to welcome Drs Terence Ho and Drs Raghaven today, who will be co-presenting on the topic of personalized management of COPD. And they are both physicians in our Firestone Institute of Respiratory Health here at St. Joe's. Our head of service for respirology is Dr. Rebecca Amer, and as we've been doing over these past months, I've welcomed Dr. Amer here to help co-introduce Drs. Ho and Raghaven and to co-host. So over to you, Dr. Amer.
Thanks. Thank you, Dr. Verhofsek, and welcome everybody. It's really my distinct pleasure to introduce Drs. Drs Raghaven and Dr. Terence Ho ahead of their presentation this morning on personalized management of COPD. Dr. Drs Raghaven completed her respirology training here at McMaster University, and she's currently an associate professor of medicine in the Department of Medicine. She's been on staff since 2012, and she works both at St. Joseph's Hospital and at the Hamilton General Hospital, so has a very big clinical education and research portfolio. She provides clinical care in respirology and internal medicine at both sites, and she has been the physician lead of the respiratory rehabilitation program since 2019, and she also holds a leadership role in the virtual care task force at Hamilton Health Sciences. Dr. Terence Ho also completed his respirology training at McMaster University, followed by a 2-year program in the clinician investigator program, whereby he completed research in complex airways disease and asthma. He's currently an assistant professor in the Department of Medicine and does inpatient respirology and internal medicine at the Hamilton General Hospital and at St. Joseph's Hospital as well. He also has a very busy triple threat practice in clinical medicine, education, and research, and really has accomplished a lot in the research domain in his short tenure as assistant professor, and holds multiple titles across the province in different entities. And on a side note, Terence was one of the first residents to go through the program when I was his program director, and so I'm very proud of everything accomplished, not credit, but I'm very happy to see Terence grow and develop into this incredible respirologist that he is. So without further ado, I'm going to Dr.
Great. Thank you so much for the kind introduction of myself and Dr. Raghaven. The topic, as mentioned previously, is shown there. And my disclosures are listed here. None of them are particularly relevant to this talk, aside from the HASO grant. And so hopefully after today, you'll be able to describe elements contributing to the heterogeneity in COPD, both during exacerbation as well as during a stable state, a distinct difference between the two. You'd also be able to discuss the merits of discuss the merits of and evidence for a personalized approach to the management of COPD. And then also utilize a pathway for which you can send patients for some exciting new opportunities in COPD, one of which I'll describe and the other Dr. Raghaven will describe. And so as many of us know, chronic obstructive pulmonary disease, at least in first world countries, is generally related to cigarette smoking. It's defined by progressively partially reversible airflow obstruction or non-reversible airflow obstruction. And you can see an example of a flow volume loop on the bottom right here. Essentially that the FEV1 is low for any given lung volume, particularly at low lung volumes, giving this scooped out appearance. In Canada, it's both common with the prevalence of 4.5% and deadly being the fourth leading cause of death. It's associated with chronic inflammation, airways, or systemically. And acute exacerbations are actually the most common reason for admission to hospital in Canada. And so the impact of COPD, particularly exacerbations, is quite vast. So in terms of hospitalizations, the mean length of stay in Canada is 10 days, and the cost has been estimated to be about $10,000 a day. And this is compounded by the fact that 30% of patients who present with an exacerbation will have a recurrent hospitalization after that. And this leads to significant financial burdens. And so this estimate of $4 billion Canadian per year is actually for all COPD management, but almost half of that is related to exacerbations. And this is data from 2010. And obviously they did an estimate, and by 2030, it's going to be much, much higher. But I suppose that's the cost of living for everything. There's also significant morbidity associated with a single exacerbation, including a reduction in FEV1 that is at times permanent, reduction in quality of life, functional capacity, and increased frailty. And finally, in terms of mortality, these statistics are from the United States, but there's an 8% in-hospital mortality, and at 1 year, 25% of patients will have passed away. So multi-factor impact of exacerbations. And so we like to think from a COPD phenotyping perspective that we've come a long way from the 1950s where Dornhorst described the pink puffer and the blue bloater, right? These are the first attempts to make some clinical phenotyping based on the degree of dyspnea, the volume status, sputum production, as well as the presence or absence of cyanosis. And this is the most recent gold, or it's not the most recent one, but it hasn't changed essentially from 2018. And they put a focus on the things in the box there: lung function, symptom burden, and exacerbations. And so if you move along from the left here, you can see that they will use FEV1 to categorize the severity initially, but then to help risk stratify patients, they'll look at both symptom burden by CAT score or MMRC. And then they will also look at either having a severe exacerbation or multiple outpatient exacerbations. So in this example, D would be someone with high symptom burden as well as exacerbation history. And I'd argue that even though these three may be a step up from previous, it's still a relative superficial patient characterization. And when we look at the heterogeneity and stable COPD, there's so many possibilities that we often don't think of when we see patients. And the first row here is just from the sputum itself. And one can perform a cell count differential of the phlegm. Essentially, it's a CBC, but of the sputum. And we can see and measure directly airway inflammation. And so the most common types in COPD are neutrophilic or eosinophilic. And that generally can help you decide what treatments patients should get. There's also the aspect of sputum culture, with some patients having Pseudomonas or other resistant organisms, and then microbiome studies, which are generally a research study at this point, but they're growing in breadth in the research world. You can also identify chronic aspiration in the sputum by staining slides for lipids that macrophages will essentially engulf when there's fat present in the lungs. The next row is imaging. and one can quantify the amount of emphysema present on just a normal CT scan. There's other kinds of CT scans, including parametric response mapping, which can identify areas of gas trapping versus emphysema, as they both appear black on a CAT scan. And then finally, there's hyperpolarized helium MRI, which is done by, which we do here on a research basis. Essentially, it looks at the ventilation defect percentage, meaning it is showing us where air will go and where it won't go in a given patient with COPD. The next group is systemic inflammations. There are patients with chronically elevated white blood cells, CRP, IL-6, and fibrinogen, with some smaller studies identifying that these all have some ability to risk stratify patients. And finally, comorbidities. There's hypercapnic respiratory failure in COPD patients. There can be cardiac disease, whether that's coronary or pulmonary hypertension, cor pulmonale. Sarcopenia, which is often thought to be related to systemic inflammation. And then sleep disordered breathing as well, which can be hypoventilation simply from the fact that the lung function is quite poor, or obesity related issues. And just to demonstrate how much variability can be in a patient, I'll discuss a case briefly. So we have a 60-year-old female presenting to the emerge with increased cough, a small amount of white sputum, as well as an increase in dyspnea. And her dyspnea overall has been worsening over the last year, going from an MMRC 3 to 4. Of note, she was discharged just 3 days ago with a previous exacerbation of COPD. The length of stay was 7 days and completed both prednisone and moxifloxacin at that time. In terms of her COPD, the FEV1 falls in severe range. There's mild emphysema previously seen on CAT scan, no CO2 retention, and 3 to 4 exacerbations per year for about the last 3 years. Medical history includes anxiety, mild cognitive impairment versus dementia, environmental allergies. She's on a LABA/LAMA combination, Ultibro, and Ventolin is needed. She lives alone. Her daughter visits frequently and has had to increasingly visit for ADLs, bathing, cooking. The physical examination reveals a borderline reduced saturation, some scattered wheeze. Labs are relatively reassuring with some chronic hyperinflation on chest X-ray. And so if you see a patient like this, there's, recurring and coming back into hospital just after a recent exacerbation, the guidelines aren't so helpful in deciding what we do with it essentially. And so the two big questions in my head are, what's the reason for this patient's presentation? And then how would you manage this patient? And we're not going to get interactive here, and I'm not going to start asking people, but the point is that that the history is complex enough so that it's hard to say one thing is the definite cause of exacerbation. Is it that environmental allergies have led to an eosinophilic phenotype in this patient? Is the patient just not coping well with the recent cognitive decline, or is anxiety playing a role for this representation? There's just a lot that goes into a representation that isn't essentially captured by the criteria that we use, right? The Winnipeg or Anthonison criteria is very useful in some instances, but if we were to use that very simply and at face value, we would say, oh, there's more sputum, there's more dyspnea, there's more cough, and therefore we will treat this person with another course of prednisone and antibiotics. And I just don't think that that would necessarily be useful to this specific patient. In some cases it is, but sometimes we have to dig a bit deeper. And so the heterogeneity of, there's heterogeneity in stable COPD, but also in exacerbated COPD. And so if you follow along with me in this flow chart from the top, there's contributing factors of exacerbation at the top. Then it splits off into what I term physiologic and non-physiologic. If we follow on the physiologic side to the left side, there's bronchitis or airway inflammation, which I described you can detect with the sputum cell count. Essentially, sputum eosinophilia responds to steroids and sputum neutrophilia responds to antibiotics. And essentially, this is where we target our treatments, right, of prednisone and antibiotics. But there's some cases where we need one, and there's some cases, there's a mixed bronchitis where we need both. And sometimes there's cases where we might not need anything. It could be also a worsening of airflow obstruction, worsening of respiratory acidosis, and worsening of LV or RV function. If we go over to the non-physiologic side, I've only made one box for it, but that's not meant to do a disservice to this. It's rather that it's a very vast area where it could be anything from anxiety, not coping well to recent cognitive change. It could be a health literacy issue. It could be other factors associated with low socioeconomic status. And so why do recurrent exacerbation happen so frequently? I'd argue that there's incomplete characterization at times for patients with COPD, both at exacerbation and when they're stable. The acute management of exacerbation is relatively, we're kind of limited in our choices, and we rely a lot on our Winnipeg criteria. And there's also less consideration for the physiologic and particularly the non-physiologic contributing factors to exacerbation. And so one of the strategies that has been tested and used is something called comprehensive care management. And it's really targeted towards the non-physiologic contributors. You can think of it as a person providing support and giving a warm blanket to patients, help them navigate the healthcare system, and provide the support so that they can learn to manage their own disease. Typical components of comprehensive care are shown here in the box on the right, and it includes self-management education, so empowering the patient to learn how to manage it themselves, inhaler techniques, smoking cessation counseling, case management, which could include booking urgent visits or availability by telephone, an individualized action plan, coordination of community and hospital resources. And I'll give some examples of this in the next couple slides of what that actually might look like in our COPD clinic. And if we review the evidence on self-management strategies, there was a recent 2017 meta-analysis. This forest plot describes the respiratory-related hospital admissions. And you can see that study to study that there's some variability in this outcome, but that there is a significant improvement in overall in respiratory-related hospital admissions. But a lot of the variability may relate to the fact that it's difficult to administer comprehensive care management since there's so many components of it in a very standardized way. So that might be part of the issue. And then part of the issue might also relate to the heterogeneity of COPD or the person that's actually providing the intervention. From the same meta-analysis, part of it's cut off, but this shows respiratory-related mortality. And interestingly, there's a trend towards increased respiratory-related mortality with the self-management interventions. And one of them in specific, a veteran affairs study by Fan et al., which was published in the Annals of Internal Medicine. It was terminated early due to an increased risk of mortality. And part of the reason it's been theorized that this may occur is that empowering patients is very useful. But if you start going on the side of things where patients are overconfident in their ability to self-manage, then they may show up to emerge and be in a much worse condition than if they had shown up earlier. Part of it also, again, might be related to controlling the non-physiologic factors and the physiologic factors remaining rampant. And so this is an algorithm that we would use for sputum-guided treatment, which is one of the strategies to target the physiologic factors. It's certainly not all of them, but one of them that we really focus on because it's underutilized. And so if you follow this chart with me, we go to left for bronchitis or airway inflammation. It can be either eosinophilic, neutrophilic, or mixed. If it's eosinophilic, it responds to steroids. Neutrophilic, if it's bacterial, responds to antibiotics. And in viral, you would have supportive treatment or if there's any specific treatment for that virus, unless you think there's a superimposed bacterial infection. If there's no airway inflammation on the right, then you can optimize bronchodilators and even consider reducing steroids if the eosinophils are low, because as we know, steroids can increase the risk of pneumonia in patients with COPD. And the evidence for using such a strategy was established with 2 clinical trials. The first here is shown on the left. These authors looked at took patients who were stable and titrated their inhaled or oral steroid to the sputum eosinophils alone. In the black circles is the intervention group, and in the white squares is the usual care group. And you can see that there's an increased time to first severe exacerbation. The figure below essentially just shows that the sputum eosinophils in the intervention group ended up being lower with steroid, and that could potentially explain the finding that we see above. A similar study looked at sputum eosinophils and titrated steroids, or also gave azithromycin for neutrophilic bronchitis, and their primary outcome was health-related quality of life. And you can see here that there's an improvement in the intervention group compared to the usual care control group. And so the COPD post-discharge clinic at the Firestone, we try to combine multidisciplinary case management and a personalized medicine approach, particularly using sputum-guided treatment. And the idea being that if we control the physiologic factors, yet the non-physiologic factors are running rampant, then we can't essentially reduce enough of the risk for these patients. So a perfect example is that we would have patients on the optimal inhalers, including a titrated inhaled corticosteroid dose that suppresses eosinophilia, doesn't increase the risk of pneumonia. Yet if the patient can't afford their inhalers, have poor technique, or just don't have the ability to use it consistently, then that person would still be at very high risk. And so the referral criteria is relatively simple. They'd have to have been admitted to St. Joe's for an exacerbation of COPD. Spirometry proof is ideal, but not necessary if there's a really high pretest probability for COPD. Typical patient might be someone with a history of recurrent exacerbation or who's at high risk for it and having multiple comorbidities. And so this is a pictorial presentation of what we try to do in the COPD clinic. And if you'll try to follow along with me, the top half of the slide is really the clinical phenotyping and guided treatment to manage the physiologic contributors. And then the bottom half is the comprehensive care management, looking at the non-physiologic contributors. And if one has an exacerbation here, we follow up with them quickly by telephone, arrange a follow-up visit, where we do that clinical phenotyping, blood work, spirometry, sputum, and then education. And then we see them again at 8 and 16 weeks, hopefully with this arrow reducing their exacerbation risk going forward. And if we go back to the top half of the slide again, if there's airflow obstruction, then we can optimize the bronchodilators. Bronchitis, we do sputum-guided treatment. Acidosis, one can consider non-invasive ventilation. And then if we go along to the bottom half of the slide again, there's education, telephone follow-up, there's a joint COPD psychiatry clinic for those with significant psychic comorbidities, and then case management for up to social work or other healthcare providers. So we're able to publish last year our experience of 1.5 years with this combined clinic in the Firestone. We had about 101 patients, mostly female, significant smoking history. The FEV1 fell in the severe range, and these patients had a number of exacerbations in the last 12 months, leading to their gold class. In terms of clinic and sputum feasibility, most of the patients that were referred end up making it to the clinic. A number were either not interested or some passed away before they got there or had a readmission. Sputum was obtained in about 40% of patients that actually came to the clinic, and the sputum was abnormal at some point during clinic follow-up in almost all of the patients that a sputum was made. And the types of airway inflammation we identified was eosinophilic in 14%, neutrophilic in 26%, and then mixed in 3%. We also focused on healthcare utilization. On the left is COPD related, and the 2 bars are in the 6 months previous to the first clinic visit, and then 6 months after is the second bar. And you can see that there's a significant reduction, and the same can be said for all-cause healthcare utilization. And when we modeled this with a negative binomial regression, there was about a 70–75% reduction in the incident rate ratio. And so most people at this point would say, well, oh, so it's only an observational study. Very true. And that's why I'm moving forward and testing this combined dual-pronged approach in a randomized controlled trial. And I'll plug a little bit at the end how you can send patients that you might think would benefit to this. And we'll move on to Dr. Raghaven's.
Thank you. So changing gears a little bit, but still looking at at the time, that vulnerable period when patients present with a COPD exacerbation, is looking at rehabilitation post-exacerbation for COPD. So my disclosures, a lot of the work that I'm talking about today, I'll talk about the funding, but I have both grant and non-financial support from BI, and then this work has been funded by OCI as well. So what is pulmonary rehabilitation in terms of a place to start? A lot of it is what we've talked about already. So comprehensive care with a multidisciplinary team. And we generally think, when we think pulmonary rehab, what everybody thinks about is exercise, but that's only one component of everything that happens, because you do have a multidisciplinary team that assesses the patient and addresses all of the other issues that we've talked about thus far. And it's well established in terms of evidence in COPD. Anyone with moderate or worse COPD really should have access to a respiratory rehabilitation program. But worldwide, there's a shortage. And here in Canada, the local data is that less than 1% of patients with COPD have access to a program. Now, increasingly over the last 10 years or so, we've recognized that those in the post-exacerbation phase are the most vulnerable. And this is the unique opportunity where we can capture them because they have an interest in improving their health at this point. They're also in a high risk situation, as Dr. Ho has mentioned, in terms of increased readmissions and mortality. And a lot of this work came about after a meta-analysis. There was a Cochrane review in 2011 that showed that those who started rehab within 30 days of an exacerbation had decreased readmissions and perhaps increased mortality as well. So this led the American Chest Physicians Group and the Canadian Thoracic Society to recommend a 1C recommendation that patients should get into their pulmonary rehabilitation program within 30 days of hospital discharge. And it was a 1C recommendation because it was quite heterogeneous data, but there was a recommendation that came out to that effect. Now, where does this leave us? So 30 days is quite a narrow window. I'll expand further in a little bit about why. But more recently in JAMA in 2020, they looked at this again. So the association between the initiation of pulmonary rehabilitation and hospitalizations for COPD and 1-year survival. Next slide. So it was a retrospective study, but they looked at a large number of patients. So they were looking at patients who had a diagnosis of COPD and who were over 65 years old. Speaking to the difficulty in doing these studies, they screened close to 200,000 eligible patients out of 5,000 hospitals. And then this was retrospective. So they selected out nearly 3,000 who initiated rehab within 90 days of hospital discharge. And then they matched them. So they did a very careful matching for all known sort of variables that could impact the comparison, and they screened the remainder of the patients to match another nearly 3,000 patients. And what they found looks quite significant. So the 1-year mortality after initiation of pulmonary rehabilitation in those who either got, so the blue line is those who started rehab within 90 days post-discharge. The orange line is those who either started after 90 days or never received rehabilitation at all. And you can see that those curves separate early and quite substantially. And what's interesting is that actually the median number of sessions attended was actually only 9 sessions. What they were offering was 3 sessions a week. And when they noticed that even a small attendance to rehab was significant, they looked a bit further. And they noticed that every 3 extra sessions, which was considered a weekly dose, was associated with a decrease in mortality. In exploratory analysis, there wasn't a difference between initiating within 30 days, as we were previously trying to do, versus within the 90 days, which, it was retrospective, but it gives us a bit of a breathing room in terms of if we're trying to get patients in. So what do we do here? We do have a respiratory rehabilitation program that's through the Firestone. We run out of the 8th floor of the Jurvinski Tower, but our referral pathway is quite lengthy and complex. So what you need to do is send a referral for respiratory rehabilitation to the Firestone. Then one of us, the physician, will do a consult. Our general wait time is between 1 to 3 months. We can see them sooner if flagged, but that's kind of the average. We then screen for, interest, adherence, ability to come and engage in our program, ruling out other comorbidities that might make rehabilitation contraindicated, and we'll refer them to the multidisciplinary team for a consult. And our wait time there between those two steps is, again, 1 to 3 months. And it's been on the lengthier side right now, just navigating through the various waves of COVID and redeployment. So we are closer to the 3 months right now. And then once the team has met the patient, they will slot them in to begin rehab, which there will be somewhere between 1 to 4 weeks, depending on when the next availability is and when the next cohort is starting. So you can see that certainly there's no way patients get in within 30 days, and even 90 days doesn't really give us more opportunity there. So in the last 10 years, about in 2015 was when Caring for My COPD at Compass Health was established, and their specific mandate was to bridge this gap. So their mandate is to get patients in within 30 days. So if you send a referral there, they run their program by cohorts without an upper cap. So they'll offer a spot to any patients who are referred. But what they've noticed as well is that even if patients are referred at the time of discharge or shortly after discharge, that patients themselves are deferring the program. So generally, once patients have left, they either feel overwhelmed or too frail to actually go and attend an outpatient rehabilitation program. So this gap still exists for us here locally. So what have we learned during the pandemic? It's shifted a lot of things virtual, as we all kind of know, in terms of our day-to-day lives. So this is true for us in rehabilitation as well. So as we had to navigate the various waves, we have had an increasing comfort level in virtual rehabilitation. What our team has noticed is that we've been able to get patients exercising to appropriate levels without equipment. So in the comfort of their own home, they are actually able to achieve a good cardiovascular exercise. Our physiotherapist has designed a seated group and a standing group. So even those who previously they would be frail or a falls risk, and we might have been nervous about having them exercise at home, but with somebody supervising who couldn't help them if they fell over, we've now developed the seated group for safety. Now, when we imagine virtual rehabilitation, we kind of think it's like the Zoom link where we can have, 40 to 100 people there at once, all exercising together. But realistically, with this group of patients, the therapist needs to have eyes on the patient. So there is still a limit. So it's about 3 patients to therapist right now, so that they can actually see them on the screen, make sure they're doing the exercises appropriately, that they're not getting into any safety concerns. The other surprising thing has been that social benefits have actually persisted online. One of the benefits of rehabilitation has always been that peer support that patients get. Some of our earliest groups in rehab, actually, when they had 2 to 3 patients exercising together on Zoom, they actually, became friends and made plans to exercise together on Zoom post-discharge from the program. So that was nice to see for us. Now, is there any evidence for this? And there is, and this area is growing, particularly, I think, as we go forward, we'll see a lot more growth in terms of our evidence, since the papers published up to now, really a lot of the recruitment was done pre-pandemic. So one of the earliest of these was in thorax in 2020, where they were looking at supervised telerehabilitation versus usual care pulmonary rehabilitation and severe COPD. And here it was a randomized assessor blinded trial. Obviously, the participants and the physiotherapists could not be blinded. The virtual rehabilitation was supervised exercise and education 3 times a week for 10 weeks. They had video conference software installed on a single touchscreen that was quite easy to use for the elderly patients. And the control was in-person exercise twice a week for 10 weeks and education once a week. So again, 3 times per week that they were connected with the team. Now, interestingly, they actually designed this as a superiority trial. What they were thinking was that they'd have better adherence to the virtual rehabilitation, and that's why they designed it in that way. And what they found was that the majority of patients approached wanted in-person rehabilitation and declined participation. So they really struggled with recruitment, which you'll see will be a recurrent theme that I talk about. There were no differences actually in adherence rates between the 2 groups. And what they defined as good adherence was attending more than 70% of the sessions. They saw small improvements in 6-minute walk test and quality of life in both groups, but they didn't quite reach significance, and they didn't see the difference that they were expecting between the groups. So it was a negative study, but they had designed it as a superiority study. Now, if we look at that critical period of 30 days post rehabilitation, this is a small study where they looked at this in our Blue Journal. Go ahead. So here they offered consecutive patients admitted with COPD, they offered them virtual rehab, and then they retrospectively matched them by readmission risk to these prospective patients. So it was a 1-to-2 matching to try to improve their statistics. Patients were enrolled during their hospital stay. They were given a data-enabled smartphone, and patients attended 36 exercise sessions over 12 weeks along with education. They were given some equipment. So they were given a portable foot peddler, resistive elastic bands, a BP cuff, and a SAP monitor. And they wanted patients to attend at least 20 sessions as a threshold. Now, what they found in terms of their baseline characteristics, these were pretty typical and fairly well balanced. They were obviously looking for the retrospective cases that would match the cases they recruited. It is patients with severe COPD, which we see, so their FEV1 was less than 50%. You can go to the next slide. And they saw quite a substantial improvement. So all-cause readmissions, significant improvement in the rehabilitation group compared with standard of care. When they looked at COPD readmissions, less of a separation there, but certainly still significant results in terms of a benefit. And then more recently, so last year in thorax, again, there was an attempt to look at this telerehabilitation for chronic respiratory disease. Again, a randomized trial. Go ahead. So here again, so they assessed 650 patients. Nearly half just declined to participate, and out of the other half, between comorbidities and other issues, they were lost and didn't proceed with the study. You can go to the next slide. So in the end, they randomized 140 patients, allocated them 70 to telerehabilitation, 70 to center-based pulmonary rehabilitation. And here they were looking for equivalence, so non-inferiority here. You can see that only in the 6-minute walk distance was the telerehabilitation, which is on the left, equivalent to in-person rehabilitation, which is interesting. These were their 3 primary outcomes. So the CRQ dyspnea domain crossed the level where it's possible that it was inferior. The endurance cycle test, which generally is a poor outcome because it's really hard to show a difference, again, crossing the boundary in both directions, so hard to make a conclusion there. Next slide. but interestingly, so no adverse events in either group. And the other CRQ domains, so the CRQ is the chronic respiratory questionnaire, which we use commonly in rehabilitation studies. So the other domains of mastery and fatigue showed equivalence, but the dyspnea domain, which is the one they stated was their primary outcome, didn't fully show equivalence. So where does that leave us here? So there's this emerging evidence that virtual rehabilitation certainly is safe, and that there may be a possibility of offering this early, so within 30 and maybe 90 days post-discharge. So we've partnered with Atonix, and we've had funding from BI, OCI, and Can Health, and we've launched a Vertex, so we make the acronym work by calling it the Virtual Exercise Post Exacerbation of COPD, which is a 10-week program where patients get live virtual rehabilitation twice a week, supervised by a physiotherapist in groups of 2 to 3 patients. We didn't have funding for a full multidisciplinary group, so instead our group has created a series of educational videos. There's a set schedule where they can attend twice per week for the 10-week period. They also get an in-person educational review with the COPD educator with their same small group to maximize some of the social aspects once every 2 weeks. And there's also optional self-directed exercise. So with this app, it can actually prompt the patients to say, you know, did you go for a walk today? Do you want to do one of these exercise videos? Our fundings come from the Ontario Centre of Excellence. Epic integration has been funded by Can Health, and BI has partnered with us to help pay for some of the tablets that we're offering in the program. And so patients receive the tablet, which is loaned to them for the 10-week duration of the program. They also get an oximeter that has a Bluetooth link to the device. Optionally, we can provide blood pressure cuffs for anyone that we're worried about, particularly if there's PH or a cardiac disease that's of concern. And where we are, we're just beginning enrollment. What we're trying to do is collect feasibility and update data as a QI project, and it lives as part of the COPD care path. So our physiotherapist works with the COPD clinic, and our pilot is going to run for a year, so till spring of 2023. The goal is to offer it to consecutive patients with a COPD exacerbation to assess uptake and assess the feasibility of this. Now, what we've already noticed is, you know, I thought it was the distance and patients getting to the program that was the barrier to rehab. What we've noticed when we've approached patients is that they're overwhelmed in hospital in general. So even signing on to say, I will guarantee that I'm going to be at these sessions twice a week is actually quite overwhelming for patients. So these are some of the things we're working through as we build this program.
Okay, so I'll just jump back in here for a slide. Essentially, if you think you're inpatient or outpatient at St. Joe's or the general hospital would benefit, the easiest way to get patients in for either the Vertex, the virtual pulmonary rehab, or my clinical trial looking at the COPD clinic and sputum-guided therapy would be to consult the COPD team at St. Joe's. Otherwise, you can just even provide details if the patient's interested to the COPD team, or email myself listed there, or Dr. Raghaven for the specific opportunity for COPD patients. And otherwise, I just have a slide here to thank the people that help us do our research and help us provide the clinical service of the COPD care pathway, including all the CTU attendings, Claire from the COPD team, ICC, Anna McPherson being the coordinator, our nurses at the COPD clinic and the Firestone staff, pulmonary rehab staff, and research collaborators.
Wonderful, thank you very much, and a tremendous team effort from start to finish as patients are presenting to clinic on through to exacerbations and then through rehab and hopefully trying to keep them out of any medical complications. Thank you both for an excellent overview. So we're going to invite now any questions that folks have. You can feel free to enter your questions in the chat or raise your hand if you would like to ask a question. And I do see that we do already have one question from Dr. Steve Wong. So please share your question, Steve.
Oh, hey, thanks. Well, yeah, I just want to echo that. What a wonderful job setting up this incredible program and post-discharge clinic. Like, that's a lot of work, and I think it's very interesting. I wanted to ask a question about the perceived pathophysiological intervention and the ability to improve these outcomes. Both in the post-discharge clinic and in the tele-rehab, like, what is the mechanism that we think is driving kind of outcome improvement? Is it just compliance? Is it behavioral, or is it better targeted therapy, or is it a mix? Like, from your expert opinion, when you review the literature, both in the post-discharge clinic and the rehab, like what's the magic sauce in there that seems to be the benefit?
Yeah, it's hard to say exactly one thing. I think the point is that person to person, one person might have a lot of airway inflammation and that person would benefit from that part. Another person might have other factors that make it hard for them to access the healthcare system and manage their own COPD. And that patient benefits from the other part. And I think you need it. I mean, not every patient will get it, but having everything together with including rehab is, provides the best opportunity for patients to get the most out of it and reduce their exacerbation risk. It's hard to really, at least kind of in a robust way, say which is more important, but certainly like having a lot of follow-up and feeling like they're supported from the nurse with telephone calls, I think is a big part of it.
Yeah, if you look at the different studies that have looked at it, they've tried in rehab, at least they've separated out the education versus the exercise component. Each individual part provides a little bit of benefit, but certainly the whole package together provides the most benefit. So, some of it is the conditioning and making patients stronger when they're so frail post-exacerbation with the muscle loss and muscle wasting and everything that you see with that. There's also the breathing techniques and learning how to cope with an exacerbation. So pursed-lip breathing, reducing dynamic hyperinflation, which helps not only during exercise, but also during those anxiety attacks. So everything really together is helpful. There's also some interesting studies that have shown that just having a phone number to call, so patients are just so anxious that knowing, as Dr. Ho mentioned, that they have a coordinator, even if they don't ever pick up the phone and call the coordinator, has been shown to reduce, readmissions and that panic sort of feeling that patients get. So I think, all of them have small additive benefits. And then when you can put it all together in the right package, it certainly is helpful for patients.
That's great. Thank you so much. And thanks for that question, Steve. And it brings to mind the quadruple aim when we're thinking about quality improvement, where we're trying to enhance the patient experience and save money and improve the care delivery and improve the healthcare providers' experience too. So where you can do that preemptive intervention to address all those aims is really exciting. We have another question here from Dr. Jerry Cox. Excellent talk, thank you. It seems there have been fewer acute exacerbations of COPD admissions in COVID times. Is this true? And if true, are there clues for us to explore to reduce COPD admissions in future? Thanks, Dr. Cox.
So yeah, it definitely is true around the world. Even there's a recent meta-analysis and the studies, I think there's like 16 studies they looked at, and it ranged anywhere from 30 to 75% reduction in admissions for COPD exacerbation. It's thought to be related to a lot of things, including virtual care, with probably an increase in outpatient exacerbations, so treating people with prednisone antibiotics. Action plans, there's a general, fear of attending hospitals related to COVID. And then there's also the question about respiratory viruses. And so COVID being around and public health measures have essentially masking and social distancing have really made other non-COVID viruses bottom out, essentially. I'm doing Natia and I are doing a study on this, actually looking back at the viral prevalences, but essentially they really fall off, particularly influenza positivity rate and number of cases in the community. And this could play a big role as well. And so some studies out there that have been reporting on this are suggesting that that maybe we should be kind of putting it out there that these preventative strategies to prevent respiratory viral spread would be a good idea in patients with airways disease. But as we probably all know, getting the patients to wear masks is probably something that they could do if they don't feel too dyspneic. But then getting the rest of the population to do so is going to always be a challenge.
Thank you very much. Very interesting, and trying to think about which of the changes are sustainable and which are really unique to a worldwide pandemic. So we've got a few more questions and comments in the chat. Dr. Amer also has your hand up, so I'll give it to you, Dr. Amer, and then we'll come back to these questions in the chat.
Thank you. And it was mostly a comment and one small question. I just wanted to thank Natia and Terrence for a tremendous talk. This was a really lovely, evidence-based, patient-centered, practical sort of guideline for individualized COPD care, which truly distinguishes Firestone Respirology from other centers across the province and Canada, and also highlights some of the emerging fantastic clinician educators and scientists that we have in the Division of Respirology. So really a treat to be a part of this morning, and thank you. Just a quick question about educational opportunities. I wonder, for some of the internal medicine residents who may be attending rounds, are there any opportunities for them to join the COPD discharge clinic with you? We always get sort of requests from internal medicine residents wanting to do more outpatient respirology related care and focusing on COPD management. I know some of our respirology residents have joined you in the COPD discharge clinic, and just wondering about how internal medicine residents may be able to access this resource. Thank you.
Yeah, so we have been having PGY1s generally attend the clinic for the last couple of years. It's on that list of available clinics. And then even some PGY2s or people with interest in respirology have asked to send me an email, and we can usually accommodate people. So definitely a educational opportunities there. And I'd say most often we do have space. If anyone's interested, they can always email me, and I can put you in touch with the COPD nurse and we can organize it for sure.
Excellent, thank you. And from Claire Chaput, our cardiology and respirology nurse practitioner, there's just a comment here, I think related to the earlier discussion. Admission rates went from approximately 500 to approximately 300 at this site. So I guess, is that per year, Claire, or maybe not, Terrence, if you know? Yes, okay, thanks for the quick response there, Claire. Great, and so now another question from Team D. I don't know who's the person typing the question. From the personalized care lens for both programs mentioned, are you standardizing data capture for these patients, i.e. frequent sputum collections, spirometry, social determinants of health, psychiatric diagnoses for future analysis and targeted intervention? Great question.
Maybe I just want to make sure I understand it correctly. I mean, at every visit, we will try to collect spontaneous sputum, and spirometry is done nearly every visit unless we don't have the capability to do it. I mean, we don't log a lot of these a lot of these data, except for when we wrote that manuscript in terms of psychiatric diagnoses. We did for the manuscript, but since then it's kind of probably fallen off. Social determinants of health, no, we don't really, even though it's incredibly important, it's not something that we actively capture.
And then in terms of the virtual rehab, we probably capture a bit more in terms of the anxiety, because the questionnaires we do at the start and end do capture mental health outcomes. So we do a PHQ-9 and then other scales, but we don't do some of the other visits because it's fully virtual. We have an intake that's done during their hospital stay, and then a discharge assessment where they come back for a 6-minute walk test. Many of the patients probably will be in COPD clinic, and we might have some of their sputum data and spirometry from sessions in between. But this one really is more of a rehabilitation program. So we will be missing some of those other data points.
Yeah, great questions. I mean, it sounds like a lot of those data would be really interesting for research purposes, and might even be something that new members of the group or new research ideas bring about opportunities to start prospectively collecting those, but very robust tracking of patient important testing and such from what you're describing. So I think it looks like that brings us to the end of our rounds today. I would like once again to thank Dr. Terence Ho and Dr. Natya Raghavan for taking the time to put together this very comprehensive and thoughtful overview of the clinical care of patients in an individualized way who have COPD. Thank you all for attending, and thanks to Dr. Rebecca Amer for joining me and co-hosting today. Our next rounds will be on June 23rd, so next Thursday, and this will be hosted by HHS as part of the new Recruit series, and we'll have a presenter from the Division of Neurology. And then our last St. Joseph's hospital rounds will be on June 30th. And we have Dr. Lonnie Pine from nephrology, who will be presenting on the relationship between hypertension and chronic kidney disease. So that should be a great wrap up to our 2021-2022 year of rounds. And then through July and August, things will slow down as everybody takes some much needed and well-deserved breaks and relaxation. So thank you all. Have a wonderful day, and we'll see you next week.